All right. All right. Good morning, everyone. Thank you for being here today. All right. I'm very honored to introduce this visiting professor lecture series. This is our second one of the academic year, but this is one of our very important ones. This is our visiting professor for diversity, equity, inclusion. And it's something that Dr. Dacus, when he started as vice chair of DEI, felt was very important that we have every year someone who can share their experiences, their story, and the struggles they've had in our profession, and how they've managed to still continue to succeed. And I think everyone can learn something from this phenomenal visiting professor today. We had a wonderful dinner yesterday where we had a lot of great discussion, but I'm going to let Dr. Dacus introduce Dr. Spiker. So thank you all for being here today. And thanks to alumni who have joined.
All right. I have notes because usually I know the person really well, and I've just had the pleasure of meeting Dr. Spiker yesterday, actually. But welcome to the fourth visiting professor in support of diversity, equity, inclusion, and wellness in orthopedics. I think Dr. Chauber kind of touted the importance of what we feel here. In a time of negative association with DEI, we're here to celebrate excellence. And I think Dr. Spiker represents that in a lot of ways for just that. She's originally from Madison, Wisconsin. She currently practices at the University of Wisconsin, so she made it back home as a sports medicine surgeon and a hip preservationist. She's familiar with the DMV, She's a grad from Georgetown Medical School and Johns Hopkins Orthopedic Program. It was in DC where she met her husband, Trevor. So I think she does have some connection in this area. So she'll come back hopefully at some point. She followed residency by 2 fellowships at HSS, one in sports medicine and one in hip preservation. As an academic surgeon, she has published numerous textbooks, articles, peer-reviewed studies. She's one of the most sought after people in hip surgery currently. I think she's had some talks in South Africa. She's going to Munich, I think, soon. She'll be in Japan as a visiting traveling fellow. And so we're blessed to have her. She's also a busy surgeon. She performs close to 600 cases a year, I think is what Winston was telling me, which is pretty phenomenal. She's also a mother of 3 daughters. So she's got a lot going on and about as down to earth as you can come. So the Midwest feel kind of comes out with her. And so she's here to speak to us about mentorship and sponsorship and also about hip preservation. So please welcome Dr. Spiker. Andrea.
Well, thank you so much. It's truly an honor to be here. So I really appreciate the invitation. And here are my disclosures to begin, none of which are relevant to this talk. So I flew here yesterday from Wisconsin, and I remember when I lived in Northern Virginia that a lot of people had a blurred sense of the Midwest. So I thought I'd put a map up here. Today in Madison, the weather's just about 20 degrees colder than it is here. We're about 2 hours northwest of Chicago. And then I'd also say this could be a map of our pipeline of UW residents coming to UVA for sports medicine fellowship. So this has been going on for many years here. So it's truly an honor to be here. I've been looking forward to this visit. I've gotten to know Winston Gwathmey over the years through courses and conferences. And a few years ago, we did a podcast together, and it was a massive success. We got 17 likes, including Winston's. So if you want to listen to a great podcast, check that one out. We have a number of former residents, as I mentioned, from UW who've been sports fellows. Emma Klosterman, one of our favorite residents, Abby DeBruyne, is a current sports fellow. And then Brian Werner and I go back as co-fellows a few years ago. Do you remember that, Brian? I found this randomly and was like, oh, wow, I don't remember that night. But at the University of Wisconsin, I'm in the sports medicine division. My practice is hip and knee sports, plus open hip preservation surgery, including periacetabular osteotomy. As as you heard, I'm a mother and a wife. I'm tenure track, so very active in clinical and collaborative research. I'm a sports medicine surgeon, so head team physician for the UW men's basketball team. And then I'm fellowship director and director of the UW hip preservation program. So in my first talk this morning, I'm going to cover each of these topics and hopefully spur discussion on what we can do to make the future brighter. So should we mentor, sponsor, or advocate in medicine? And the reason this question came to mind was because when I began mentoring medical students as a faculty, I knew I wanted to give back to the field. I wanted to pay it forward. I wanted to make the process easier for those than perhaps it was for me along the way. I thought I could offer advice based on my own experiences, be a sounding board for trainees making their way through education in orthopedics. But I learned that there was actually a lot more to mentorship than I previously knew. And I understand that nowadays the trainees are getting more of these lectures and understand more of the differences. But I can honestly say that it wasn't until about 2 years ago that I really understood the differences that existed in mentorship. And then I'll also talk about where role modeling fits into this as well. So the word mentor came from Homer's Odyssey, where Mentor was a friend of Odysseus. And when Odysseus, if you remember from the story, went to fight in the Trojan War, Mentor became a teacher and trusted advisor to Odysseus's son. So we now think that classical mentorship provides either psychosocial or career support, or both types of support. And this can be from one person, or it can be from different mentors. And mentors are basically advisors who give advice, guidance, and insight. Now, coaching is different than mentorship because coaching provides directed guidance for a person's development. It's often focused on specific skills, and it involves formal performance evaluations, developmental feedback, and a coach can sometimes be a mentor, but coaching is often measurable, specific, it's short-term, and it's a little bit more formal. Now, beyond feedback and advice, a sponsor uses his or her influence to advocate for their mentee. Sponsors tend to act while mentors advise, and sponsors act to help their mentee gain visibility in the organization. So sponsors really fight to get their protege to the next level. Advocacy can be something that sponsors do as well. So an advocate champions the person to the appropriate audience, works actively to extend the visibility of the protege, and an advocate uses the power of connection to get the protege into the right circles and puts his or her social capital on the line to help that protege. And then a role model can be any one of these: a coach, a mentor, a sponsor, an advocate, or even none of these. A role model is an individual whose behaviors or actions you learn from through observation. A person can have multiple role models for different strengths, skills, or talents that he or she wants to emulate. And a role model does not even have to be somebody that you know. So when comparing mentorship to sponsorship to advocacy, a mentor can be somebody at any level in their career or training who provides emotional support, feedback, or advice, who increases the mentee's sense of competence and self-worth, and focuses on the mentee's personal and professional development. So a mentor guides and advises, which is different than a sponsor or an advocate who takes direct action. So a sponsor must be somebody in a more senior position, and they can expose that protege to other people in senior positions. A sponsor makes sure that person is considered for promotions or career advancement, and someone who fights to get that promotion to happen. An advocate is a sponsor who champions that person to the appropriate audience and extends that person's visibility, and then uses the power of his or her own connections to get that person in the right circles. Now, mentorship can lead into sponsorship, which can then lead into advocacy, but they don't have to be connected. So mentorship may occur during a specific component of psychosocial or career growth. A sponsor might meet the sponsee after he or she has achieved a certain level of career success. And an advocate may only know the sponsee through the efforts of a sponsor. and then takes it to the external advocacy level. Now, research has shown that people gain more satisfaction from mentorship, but they need sponsorship, because without sponsorship, a person can be overlooked for promotion, regardless of how competent they are. And sponsorship actually becomes more important when you're mid-career or beyond, when there's increased competition for promotions and career advancement. So this topic has been well studied in the business world, but why is it important for us to talk about it in medicine? So when I was putting together this talk, as I usually do, I start in PubMed, and with mentorship and sponsorship, I came up with 222 results. So it's been described in medicine, but as I mentioned before, I really hadn't heard about it until a couple of years ago in my own career. And maybe that's because there's a lot less written about this in orthopedics. So mentorship, sponsorship, orthopedics, 14 results. So let's talk about a little bit about sex diversity and gender diversity in medicine and orthopedics. So first, to make sure we're on the same page as far as the terms sex and gender. So sex is biological, whereas gender is self-identifying. So in research, male and female refers to a person's biology, and man and woman refers to a person's gender. So women now represent over 50% of medical student matriculants. This is an improvement from the early 1990s when that was about 30%. But in 2018, approximately 64% of all practicing physicians were male. And certainly we can hope that female medical students make up approximately 50% of the class now, that in the future, hopefully this number will get closer to 50-50. But unfortunately, studies have shown that it's not the numbers alone that will predict this change. So we can't just rely on the fact that over 50% of medical students are women. Women in academic medicine don't advance in their careers at the same rate as men. They are far less likely to have senior positions or even have salaries that are commensurate with those of their men partners. So now I'm going to move into sex and gender diversity in orthopedic surgery specifically. And first, I'm going to talk about the orthopedic surgeons themselves. So when looking at active physicians in the United States, this is AAMC data from 2021, where the blue bar represents the number and percent of females. And so as we scroll down, you can see that orthopedics has the fewest number of female physicians in all of medicine. And interestingly, they broke down orthopedic sports medicine as having 7% females, and then orthopedics as having 6% females. So here's orthopedic surgery. And, you know, I think we've heard these numbers before, and we were just discussing this last night. Perhaps this number has increased slightly, but it's still pretty appalling that in all of medicine, orthopedics is the least sex diverse field that there is. And I don't have the solutions today to fix this quickly, but I hope that talking about it today, mentoring our orthopedic surgeons of the future, this is all part of the solution. Orthopedic surgery still has fewer females than any other stereotypically male-dominated field, such as neurosurgery, urology, plastic surgery, or general surgery. And so even though greater than 50% of medical students are women, and have been for many years now, only 14% of orthopedic surgery residents are female, and about 7% of the AAOS surgeons are female, based on 2019 data. And not to belabor this point, but we're still the lowest percentage of women residents in any subspecialty in medicine. So why might this be? Well, in one study, the reasons that medical students cited for not choosing orthopedic surgery included that about 78% of them perceived the inability to have a good work-life balance. 74% thought there was too much physical strength required. And 69% noted a lack of strong mentorship in orthopedics in medical school or earlier. And unfortunately, if you look at the data over the past 20 years, while there has been some improvement in sex diversity in orthopedic surgeon trainees, it's truly been quite minuscule, especially compared to some of the other previously severely underrepresented fields. So let's look at neurosurgery, for example. In 2005, they had 11% female residents. They had a 57% increase by the year 2016. Here's thoracic surgery. In 2005, they had 10% women. By 2016, they had a 111% increase in female resident representation. And here's orthopedic surgery. So in 2005, 11% female residents. And by 2016, that had increased by 14%, which is increased to 14%, which is only a 27% increase over 2 decades. We're rock bottom still. So at this current rate, it's going to take 217 years to achieve gender parity with the overall medical profession. So that's year 2020, 236. And it's going to take 326 years to achieve equal representation with women in orthopedics relative to the general population, year 2,354. So obviously we have to do something to change that trajectory. So as we heard from the previous study, 74% of medical students had a perception that too much physical strength is required in orthopedic surgery, and this is a reason they decided not to go into it. But in reality, yes, it's a physical job when compared to a desk job, but our instruments and technology these days really make it so physicality is not a barrier to our ability to perform surgery. Another reason is perceived occupational hazards in orthopedic surgery. So some of our cases require fluoroscopy, and in my super subspecialty of hip preservation, I spend the entire day wearing lead. Now, we do have ways to mitigate these exposures so that they shouldn't be as much of a deterrent. There are plenty of orthopedic specialties which don't use fluoroscopy, for example. And for me, I have lead glasses. My lead, as of this past year, now has sleeves added to it, which I think weigh an extra 10 pounds. I have lead gloves when I'm doing hip arthroscopy cases. So there's ways to mitigate these exposures. Now, women also have a negative perception of the male dominance in the profession and a perception of a difficult lifestyle after training. And studies have shown that when you compare female orthopedic surgeons to male orthopedic surgeons, the female orthopedic surgeons do have a greater burden in parenting and household duties than male orthopedic surgeons. And the question of whether a career in orthopedic surgery affects a woman's fertility was recently studied. In female orthopedic surgeons, the average age at giving birth to one's first child is 33.5 years old, and 53% intentionally delayed childbearing because of their career choice. 24% had complications during pregnancy, and that's higher than the national average of 17%, but it's actually lower than other surgical subspecialties, which had about a 35% complication rate in pregnancy. And there's no increased risk of fetal abnormalities in orthopedic surgeon mothers compared to other surgical subspecialties. Now, what about family planning? So more women in orthopedic surgery require fertility treatment to start families compared to male orthopedic counterparts. So about 32% of female orthopedic surgeons require infertility treatment. That's about 11% of male orthopedic surgery surgeons' families that require this. Now, women orthopedic surgeons are more likely to defer childbearing until the completion of their medical training. About 63% say they do, compared to 31% of male orthopedic surgeons. And this is the current status. And certainly this has to be an area that we focus on more research and figuring out ways that we can make a difference here. So now let's talk briefly about sex and gender diversity in orthopedics related to our patients. So growth in women's sports medicine, sports participation has really exploded since the passing of Title IX in 1972. So Title IX states that any secondary or collegiate school that receives federal assistance must offer equal athletic opportunities to males and females. And so since the passing of Title IX, high school athletic participation of female athletes increased more than 1,000% and increased more than 600% at the collegiate level. The types of female patient-specific concerns we have varies by age. So from age 10 to 50, RED-S, which stands for Relative Energy Deficiency in Sport, is the most important bone health and orthopedic issue. So RED-S was previously known as the female athlete triad, but it was renamed so that it could be applied to males as well. And the syndrome of RED-S refers to impaired physiological functioning caused by low energy availability. So one of the many manifestations of this is impaired bone health, which is very important to us as orthopedic surgeons. Athletes and patients with oligomenorrhea or amenorrhea or measured low energy availability have decreased bone marrow density, altered bone microarchitecture and bone turnover markers, decreased bone strength, and an increased risk of stress injuries. So you can imagine a situation like Bobby Clay. So Bobby Clay was a British running phenom with an eye on the Olympics, and she was diagnosed with osteoporosis at age 18. She was doing a flip turn in the pool during cross training and she broke her foot. So not only was this a problem because she couldn't make it to the Olympics, but because most of her bone mass is accrued before the age of 20, she has now lost out on the opportunity to set a high bar for what is certainly going to be continued bone loss in the future. So now moving on to another female patient-specific diagnosis, that's menopause. So the mean age of menopause is 51 years old, and perimenopause is typically occurring about 10 years prior to that. So patients in their 40s. So I acknowledge that we are now talking about menopause, but I promise to bring this back to mentorship, sponsorship, and advocacy soon. So hang in there with me. So this article was just published this past summer, and this describes what the authors call the musculoskeletal syndrome of menopause. They highlight that 47 million women enter menopause annually between the ages of 45 and 54, and they have symptoms that last typically 2 to 10 years. About 70% of these women are experiencing the musculoskeletal syndrome of menopause. So these symptoms are related to the precipitous drop in estrogen, and this results in musculoskeletal pain, arthralgias, loss of lean muscle mass, increased risk of fracture, increased tendon and ligament injury, and adhesive capsulitis. And it also causes cartilage matrix fragility. So this is a quicker progression to osteoarthritis. So if you're seeing a 45 to 55-year-old patient in your clinic, this is something to keep in mind. Now, during menopause, women lose about 10 to 12% of their bone marrow density per year. And so by age 80, women have lost approximately 30% of their peak bone mass. And this is problematic because, again, women are starting with about 30% less peak bone mass than males. And in my practice, I've been surprised by osteoporosis during surgery. So one example is during an ACL reconstruction. It requires bone tunnel interference fixation to suspend the ACL graft. And if the trabecular bone can't hold the fixation, the graft will fail. This is also seen in rotator cuff surgery, where tacking that torn rotator cuff tendon down to the greater tuberosity with anchors. But if the bone can't hold those anchors, they typically pull out, the rotator cuff repair fails. And now that many of these anchors are made of PEEK, you may not even notice the failure on an X-ray, but obviously this is a significant problem and quite symptomatic for the patient. Now, with popular sports like pickleball increasing, you can imagine athletes that have a sore back who actually have a vertebral compression fracture. And I also perform abductor repairs in my practice. And like rotator cuff repairs, these require anchor fixation to the bone. And even though greater trochanteric bone is often quite robust, patients with osteopenia or osteoporosis will have a failure of that surgery as those anchors pull out. Also in my practice with PAO surgery, patients even in their late 30s and early 40s will have poor bone quality that results in non-unions of the PAO. So to prevent injuries due to low bone marrow density, the best thing we can do is actually to mechanically load the bones in childhood and adolescence, which leads to a maximum bone density formation. A 10% higher peak bone mass in young adulthood may actually delay the development of osteoporosis by 13 years and reduces the risk of lifetime fracture by 50%. So now, because one of my areas of specialization is hip preservation, I'm going to talk a little bit about how male and female hips differ. We'll go more into this in the next talk, but there are few generalizable differences in male and female hips in patients that we see. So the male hip is often different morphology. More often, males have impingement where females have dysplasia. And if you look at the spectrum of hip problems, you can see they're on opposite ends of the hip pathology spectrum. When it comes to the type of impingement that patients experience, this is also different by males and females. Males more often have cam type impingement, whereas females have more types of pincer impingement. And when you see patients who have hip arthritis, we know of a few diagnoses where they lead to an increased risk of arthritis. And so in females, they're more likely to have hip dysplasia, whereas in males, they're more likely to have femoral acetabular impingement. Now, femoral version abnormalities are another area where we see differences in male and female patients. In general, females tend to have more femoral anteversion, while males have more femoral retroversion. And male hips tend to be more stiff, while female hips tend to be more hypermobile. So I get the Baton score to test for ligamentous laxity on every new patient that comes to clinic. And this helps evaluate for this potential variation in hips that we see especially in female patients. So what does the current long-term literature say about how male patients do versus female patients do after hip arthroscopy? Well, here's an example of 10-year published outcomes. So you think 10 years of follow-up, this is good research, this is good to put out there. But their conclusion was that females do worse after hip arthroscopy at 10-year follow-up. So the problem with this data is that these are based on surgeries that are outdated. So in this particular study, for example, the hip capsule was left open after surgery in 100% of cases, whereas now in my practice, in 100% of cases, I'm closing the hip capsule. These surgeries all took place before 2010, and it wasn't until after 2010 when the first publications came out noting the differences between male and female hips. So there were likely incorrect indications and misdiagnoses in those female patients, which led to worse outcomes. In the United States, more females are undergoing hip arthroscopy than males. And because hip dysplasia is so much more common in females, it's probably pretty likely that those female patients with dysplasia are getting inappropriately treated with hip arthroscopy alone. And there's actually new language that's emerged as we've talked more about the nuances of different hip anatomy. We have terms such as microinstability, focal acetabular undercoverage, occult dysplasia, segmental or circumferential labral reconstruction, or capsule plication. These words didn't exist when those original surgeries were being performed. So after all that talk, focusing on our female surgeons, our female patients, I wanted to revisit the literature that says female researchers are more likely to report findings as they differ by sex or gender. So as a female orthopedic surgeon giving you a talk today, I just use this forum to tell you about the differences in females and males, in orthopedic surgeons, in sports medicine, and in our patients. And that's how I'm going to tie it back to the title of our talk, Mentorship, Sponsorship, and Advocacy. So with a vast majority of especially hip preservation patients being female, we should look at the relationship between a surgeon and his or her patient. The relationship is a complex one, but we do know that patients who identify with their physicians feel heard, feel understood, and are more adherent to treatments and have quicker recovery from their ailments. And despite hip preservation patients being a majority female, we know that orthopedic surgeons are mostly male. And again, orthopedic surgery has fewer female surgeons than anywhere else in the medical field. So this article made it to People magazine last year. It's still a topic that needs more exploration, but it's in the public eye now, so it's worth us mentioning it. This People magazine article was based on this JAMA article, which found that female surgeons had better outcomes, fewer fatalities, and fewer complications than male surgeons for common surgeries. The authors couldn't clearly explain in their article why this was, but some of the reasons they thought were perhaps that, they described the possibility that female surgeons listen more to their patients. They found that female surgeons operated more slowly than their male counterparts by a few minutes. Female surgeons are more by the book, is what they postulated. But there really wasn't a clear answer, but something that we can discuss and think about more. So what can we do to improve sex and gender diversity in orthopedics and up our ante on mentorship, sponsorship, and advocacy? So this diagram shows the type of gender equity programs available at medical institutions in a survey in 2017, so now about 8 years ago. Not all medical schools have such programs, but you can see that the types of programs that exist are either at the individual level, the interpersonal level, the institutional level, at the academic community, or at the policy level. And I've now discussed a number of reasons that we can use more women in orthopedic surgery. And one of the ways to get there is mentorship, sponsorship, and advocacy. Role model of the same gender or ethnicity has been reported to be more of a positive factor for women than men. So about 59% of women say this is extremely important compared to about 25% of men. And research has shown us that women highly regard role models in the field as a resource when determining a career choice. So the lack of visible female role models in male predominant specialties can impact the recruitment of women. Mentorship is associated with an increased academic productivity and improved work efficiency among women particularly. And established mentorship programs can increase recruitment of women to a specialty. So there's now been research showing that these efforts work. We have some unpublished data from our institution that we just completed. We looked at the orthopedic surgery match data from 2020 over the past 4 years. And we found that fortunately there is an increasing rate of women matching into orthopedics. In the 2023 match data, 24.3% of the matched residents were women. And this was a steady increase from 2020, at which time it was 19.8% women. We found that an increasing percentage of current women faculty and current women residents each demonstrated a modest association with increased matched applicants. And we calculated that a 10% increase in faculty correlated with a 28% increase in the odds that the next matched resident would be a woman, and that a 10% increase in women residents correlated with a 21% increase in the odds that the next matched resident would be a woman. So this is working, and this is something we were talking about, that once the ball gets rolling, it is somewhat self-perpetuating in increasing diversity in the field. And perhaps the introduction of social media has given us another way to help our research endeavors. So of the nearly 2 million academic reports published annually, 50% are only read by the authors, journal editors, or reviewers. So a majority of the academic publications are never even read or cited. But heavily posted studies are 11 times more likely to be cited. So 75% chance versus 7% chance. And articles that were posted were not only cited more often, but they were cited earlier in their publication. So there's a significant effect of dedicated social media strategy, including posting about papers, research, or chatting about them. And this affects page views and downloads or citations. Now, what about a patient's perception of our abilities? So we published this study a few years ago in which we surveyed patients in our sports medicine and foot and ankle clinics. We had one male and female surgeon in each of those clinics, and our patients were the ones who took the survey. So our results showed that based on survey responses, patients generally preferred both male and female surgeons who wore white coats. Scrubs were especially important for females to be perceived as more able to perform the physical work of operating. Males were more often identified as surgeons compared to their female counterparts, no matter what the attire was. And females who wore scrubs with a white coat were thought to be more likely to have a good surgical outcome. So we published this right around the start of the COVID pandemic. And since that time, I have switched my attire in clinic. I wear scrubs and a white coat to clinic every day. And hopefully it's making a difference. Now, if we return to the concept of mentorship and sponsorship, this Harvard Business Review article concluded that women are over-mentored and under-sponsored. Women don't receive the same career benefits as men do from mentorship. So women truly need sponsorship to take their careers to the next level. And in the business world, males had mentors who were in higher positions than females. So both males and females tended to find their mentors on their own, and females are finding mentors that are less successful, if you will. Now, while this has been reported in the business literature, you can see this manifest in orthopedic surgery as well. So you see here the orthopedic surgeons represented, these are female orthopedic surgeons, are represented by the black bars on this diagram. And the higher up in leadership we go, the fewer female orthopedic surgeons hold those leadership roles. Now at Wisconsin, we have a female orthopedic surgeon chair, Dr. Tamara Sharpella, but she's one of less than 10 total in the entire nation. Now, another thing we can do is raise awareness of the impact our words have in letters of recommendation for trainees and surgeons applying for promotion or higher roles. So women are often described in letters of recommendation with communal traits, which reflect peacemaking behavior, nurturing, gentleness, or kindness, while men are described with agenic traits, which are considered leadership-oriented, such as representing confidence, assertiveness, and influence. Examples in this study included adjectives such as delightful, helpful, compassionate when describing women. And men, on the other hand, were described as stars, impressive, exceptional, and bright. So these are things that we can really think about and when we're writing letters to make sure that we don't fall into this trap. Now, I was recently co-author on an article summarizing the next steps for advocating for women in orthopedic surgery. And fortunately, this is something that is on the radar of the AAOS. They've developed tactics in recruitment, selection, retention, and culture, which are geared at improving diversity and leadership. And we can also continue to mentor, sponsor, and advocate through programs like the Perry Initiative, which is geared toward medical students and high school students, introducing them to orthopedic surgery. I also feel that any efforts that put me in a teaching, mentoring, or educating role can help recruit other females to the field. And personally, another way that I try to serve as a mentor or perhaps as a role model is to be visible. So I'm, too often I'm the lone female surgeon on the podium, but I keep saying yes to speaking opportunities, to opportunities to teach and educate so that I can be visible to those future trainees who might consider this field as well. And if you see the opportunity to mentor, sponsor, or advocate, take it seriously, because this really does make a difference, as we've seen from the literature, especially for those underrepresented in orthopedic surgery. So in summary, there are significant differences between mentorship, sponsorship, and advocacy, and we need to do all of these in medicine, but especially in orthopedic surgery, to increase diversity in our field. We're going to help our physician workforce, we'll improve research, we're going to help our patients by doing so. And I focused on sex diversity and gender diversity in medicine and orthopedics in this talk, but I would be remiss not to mention that this is of the utmost importance in racial diversity, as well as diversity of gender identity, sexual orientation, culture, and interests, as well as others. And all of the concepts that we discussed today can be applied to diversity, equity, inclusion in all regards, including in medicine and orthopedic surgery. So thank you very much. I'm interested in taking any questions or comments.
Questions?
There's got to be questions. You better yesterday. So you showed how like nurse surgery, plastic surgery, general surgery are basically doing a better job than we are in terms of trends. Do you think that's just the sponsorship, or like what are they doing that we're not doing well, I guess?
Yeah, that's an excellent question. And I think You're absolutely right. I think it is a directed initiative that has taken place in those subspecialties, which has not happened in ours. So all of those mentorship programs, leaders in their fields becoming sponsors and advocates for others, and recruiting other females. And I think, if you look at that unpublished data that we just finished analyzing, it really shows that if you recruit more women faculty, that correlates with matching more women residents. So starting at the top, will propagate the process going forward.
So, thank you for sharing your story and your research and efforts in this and in this area. As we talked about in length last night, it has to be it can't be a short game here. You have to play the long game to have success in this area, and it has to be very specifically planned as part of the culture of your program. And in this room, I was just looking around this room this morning, it's very different than it was 5 years ago, 10 years ago, in terms of how inclusive we've become as a program. But what advice do you have for young faculty and young surgeons, residents, fellows, in terms of choosing mentors, sponsors, advocates? What advice do you have? Because frequently you can choose a mentor or a sponsor that will not support you in the way that you need to be supported.
Yeah, well, I think, and I also want to acknowledge that, this is, you have an amazing department. It's very diverse, and that is a big credit to the leadership here, which it takes initiative and focused efforts. And so I'm incredibly impressed with what you've accomplished here. But I think one of the things that was very impactful for me is, I found mentors along the way and didn't realize that they might not be sponsors. And unfortunately, you have a very close relationship with your mentor. Maybe they teach you the skills that you need to learn to do surgery or to do research, but that doesn't automatically make them a sponsor. So when people are, inviting you to committees, inviting you to speak, they may stay silent. And so I think you have to actively recognize that. And it's, it's not necessarily a fault of their own. I have mentors who are not sponsors to anybody they've ever mentored. That's just kind of their approach. They're very invested in the individual, but then beyond that, they stick to their own practice and don't do much else. And so I think recognizing the difference, and that's something that as I mentioned, I didn't really understand that until even just a couple of years ago, many years into my practice. So I think finding individual sponsors and advocates, and also advocating for yourself to say, I need a sponsor, I need an advocate. Will you be that person for me? I'm willing to do the work. Please help me with this. And I think that's extremely important.
I learned that early in my career, that a lot of the mentors I thought who would sponsor and advocate for me, for whatever reason, maybe concerns about their own practice or own leadership positions, were not willing to expend political capital for me. And then you had to find sponsors who were not your mentors initially. But I thought it was very important that the comment you made, that your mentor may not be your sponsor or advocate, and your sponsor and advocate may not really be a mentor, but just someone who wants to help promote your career. And often by promoting your career, they get a benefit out of it. And that's why they're your sponsor or advocate. And I think it's a situation where they have a benefit too. Whereas I think a mentor doesn't necessarily benefit as much, other than the reward for teaching and advising, because that's rewarding. But I often find that sponsors and advocates are helping you because it benefits them as well.
Yeah, an extremely important distinction. And you can get derailed if you don't recognize the difference.
So Andrea, I consider myself a mentor, career-wise, and I would like to try and talk to everybody going into hip arthroscopy or sports medicine. My hardest conversation, so as far as trying to mentor especially women, is work-life balance and family planning, those types of things. Can you provide some guidance, especially those to the female residents, like how you've done, you have 3 children, you've got a husband, you're balancing it all while still becoming an excellent orthopedic surgeon. Like how do you navigate the work-life balance?
Yeah, I think that is the most challenging part of my life is that work-life balance. And I do think that there is something to be said about creating the path. So I think about maternity leave, for example. So I was not the first resident at my residency program to have a baby, but there weren't that many before me. And my residency program director, Dr. Laporte, was incredibly supportive. She herself had been a resident at that program and had a baby during residency. And the lore was she came back the next day after she delivered and she routed on patients. And at the time, she was the first person to have a baby in residency. And so that was kind of the expectation. Now, years later, I had my first daughter as a chief, and I asked for a week off and ended up with 12 days postpartum. And I remember my junior resident, I was going to come back on call on Saturday at 12 days after I'd given birth to my first child. And my junior resident called me on Friday and was like, we need you to come back tonight instead, So I think that having gone through that, that was 12-fold longer than Don Laporte got to take off. And now we have residents in my program who take 3 months off, and it's that's a lot, or 6 weeks off, and they come back. And so I think there is something to be said about not having that work-life balance in my stage, but by going through that, the trainees below me have the ability to have a better work-life balance. So I think of it as a little bit of sacrifice in that sense. But it is a lot of, I tell a lot of the mentees that shadow me in clinic,
I probably work harder than I would ever want them to work. I get less sleep. I stay up late hours doing all these different things. But part of that is so that somebody else doesn't have to do that in the future, that the path has been cleared. So I don't know that I have a good answer for it. I also think about it in stages of life, at certain stages right now, I admit I don't have any hobbies right now. So I'm glad nobody's asked me what my hobbies are, because I don't. I have work and I have my kids and my family. So that's it.
I always thought about the concept of the unicorn, right? So you kind of are that to some extent. In a lot of these scenarios, like panels where they're like, well, we have a woman, right? We have a woman who's also a minority or some sort, right? And so you meet all the metrics so their data looks like a certain thing, but it's consistently the same person, right? And so what we found in the hand society is that's pretty consistent for us, is that we not only don't have diversity on panels, we don't have diversity amongst the marginalized groups as well. It's the same person doing things over, doing 10 different talks in a meeting. Do you have a network of people similar to you that are in similar scenarios that you communicate with, that you can build on, that you kind of do that? Or do you feel like to some extent you're out there by yourself?
Yeah, my network has been growing for sure. And so I think that's something, kind of putting your head down and plowing ahead, saying yes to all the opportunities to speak very early on, because I know that the next person who's going to be asked is going to be another male colleague. But now, when I can't make a talk, I have identified, I don't say, no, I can't do it. I say, ask so-and-so, or this female orthopedic surgeon, or this, orthopedic surgeon. And we recently just hired another orthopedic surgeon, another female hip arthroscopist. So I was part of that recruitment process and mentoring her and, helping her get off the ground for arthroscopy. And, you know, I think by doing this, by kind of putting myself out there, even though I was that same person for many years, well, now I'm, you know, chair of programs and I get to pick who's on my faculty. And so I do have much more say and I'm very aware of making efforts to make it more diverse. And then hopefully each of those individuals will do what I've done, you know, for a while, be the only person, but then have the ability to pull other people into the fold.
Any more questions? So before we start our next talk, I want to just present you with appreciation as our visiting professor for DEI, as well as some UVA Ortho swag. Please wear this around Jeff Baer, because he hasn't come back for an alumni meeting, and I'm not giving him anything until he does. So please, hopefully he'll be here this April when we have our alumni meeting.
Thank you.
Just a few things here.
Thank you.
Thank you. We'll take a break because people start to see that. We have one of your colleagues. The radiologist, he got lost. Yeah, I don't know what else he was. Take a break. Yeah. Okay, well, we're gonna do our second talk. Can you ask that question? No, go ahead.
Like suddenly,
Get your letters done.
like, yeah, just send me my
Yeah. That's my coffee.
I'm so sorry, Dr. Calbro.
Have seen the person.
I'm so
Will you be, you'll be around after this or do you have to, okay, all right. Okay, awesome.
Yeah.
All right. So I'll go right into my second talk on the limitations of hip preservation. And as I put this together, it really morphed into the limitations of hip preservation and how we can overcome them. So we heard a little bit about my journey earlier today, but I wanted to start by just talking about my hip preservation journey. And so I'm from Madison originally, as you heard. I went to Wellesley College. I worked for 3 years before medical school as a speechwriter for the National Science Foundation. I lived in Berlin, Germany for a year on a Fulbright scholarship, and then worked at Virginia Hospital Center in Arlington as a phlebotomist and medical tech while I was applying to medical school. And then Georgetown, Hopkins, and HSS. And I saw my first hip scope in residency. In residency, I saw a total of 4 hip arthroscopies. I never saw a PAO. I did a lot of pediatric osteotomies with Paul Sponsler at Hopkins. But my interest in hip preservation really began in sports medicine fellowship. My first rotation, randomly assigned, was hip arthroscopy. And that's when I really started to recognize the nuances of the hip and started to think of it as the final frontier in orthopedic surgery. So I stayed unexpectedly for, I wasn't planning to do this initially, but then I stayed for a second year fellowship in hip preservation. And now at the University of Wisconsin, we have a hip preservation program. We've established a multidisciplinary group that treats all types of non-arthritic hip pain. And I actually take call at the hospital that I was born at. So Today, I'm going to break this talk into two separate sections. The first will focus on the technical aspects of what we can accomplish with hip preservation surgery, when it's not the answer and when we can't know for certain, which really highlights our limitations. And then we'll discuss bigger picture limitations of hip preservation, including our competition with the hip replacement, the learning curve, patient-reported outcomes, and then I'm going to come back a little bit to diversity, equity, and inclusion in orthopedics and hip preservation. So to start, what is hip preservation? The simple answer is that it includes interventions, both non-operative and operative, which maintain a patient's need of hip and delay or prevent the need for a total hip replacement. So what can we accomplish with hip preservation surgery? So as you saw earlier, hip pathology really falls into two sides of the spectrum. There's static and dynamic mechanisms. And using the most common diagnoses as an example, a static mechanism would be hip dysplasia or under coverage of the hip socket. And then femoral acetabular impingement would be a dynamic mechanism. And when we think about what we can do for these two diagnoses, we really only have limited tools at our disposal. We can correct the pathomorphology or change the shape of the joint. We can realign malalignments. We can repair or augment or reconstruct soft tissue, such as the labrum. Or we can address cartilage damage, though we still don't have a great way of repairing cartilage once it's lost. So taking hip dysplasia, defined as a lateral center edge angle less than 25 degrees, as an example of static hip pathology, the gold standard treatment for this is the periacetabular osteotomy. So the goal of the periacetabular osteotomy is to cut the hip socket free from the rest of the pelvis and then rotate that fragment to make sure that it's not hinged anywhere around the joint, providing better coverage for that femoral head. So the PAO basically gives the dysplastic hip the same natural history as a normal hip. It's a really powerful operation, not only in treating symptoms, but in preventing the development of osteoarthritis. And then as far as the dynamic hip pathology that we see, in each of these scenarios, impingement occurs with dynamic motion. And you can see cam type, pincer type, or subspine type. And in most cases, there's some combination of all of these impingements occurring at the same time. Now, the goal in cam type impingement is to remove the excess bone on the femoral neck. The goal in pincer type impingement, as seen here, is to remove excess bone at the hip socket. And then the goal in subspine type impingement is to remove that bone beneath the AIIS in order to prevent impingement there. Now, just within the past year, we actually have good long-term evidence that hip arthroscopy and cam resection does reduce the risk of developing arthritis. So this has been something in the field of hip preservation where we always thought this was the case, but it wasn't until last November that we actually had the data to support it. So 2 studies came out this past year with up to 15-year follow-up. And they found that those who had hip arthroscopy with cam decompression had a decreased risk of progressing to arthritis. It's about a 42% relative risk reduction at about 15 years follow-up. So finally, we have the evidence to support what we've all been believing. Now, another situation where hip preservation surgery can be useful is with femoral version abnormalities. Normal femoral version is about 15 degrees of anaversion. And so the treatment goal with derotational surgery is to restore femoral anaversion close to what we consider normal. And there's a few ways that we can test for this. The foot progression angle, whether in-toeing or out-toeing, may be an adaptation to avoid pain due to either instability or impingement. So watching a patient walk down the hallway will give you insight into his or her femoral version. And then you can correct this a number of ways with an intramedullary saw and nail, an intertrochanteric blade and plate, a subtrochanteric osteotomy and plate, or a distal supracondylar osteotomy and plate. And with the association between excessive version abnormalities also being a cause of hip arthritis, if you correct this, then you can prevent that arthritis from occurring in the hip. So when is it clearly not right for hip preservation? One of the clearest contraindications for hip preservation is advanced hip arthritis, no matter the age of the patient. So we know that patients with osteoarthritis don't do well after hip preservation surgery. They ultimately go on to need a total hip replacement at an unacceptably high rate. And so catching this and making sure the right surgery is performed is really important. The symptoms that a patient presents with can help us differentiate arthritis from other forms of hip pathology. And usually those classic terms of achy, constant pain at rest, startup pain correlate with arthritic pain, whereas femoral acetabular impingement symptoms are often more mechanical, sharp anterior groin pain with specific movements. And most often these are deep flexion or internal rotation of the hip. Pain's not often constant, and they don't typically feel pain at rest. So what are the situations where we can't know for certain? And this is where it's really important to understand what the limitations of hip preservation surgery are. So outside of the osteoarthritis contraindication, it's really not that clear when to draw these lines. So here is where it's important to keep Brian Kelly's 4-layer concept, the etiology of hip pain in mind. So layer 1 represents the osteochondral layer, layer 2, the capsuloligamentus layer, layer 3, the dynamic or musculotendinous layer, and layer 4, the neuromechanical layer. So this really allows you to imagine some of the more complex pain generators that might exist around the hip and that we can't really help with hip preservation surgery. So when we work up these patients for causes of their hip pain, I like breaking it down into a 3-step approach. So first, we want to confirm that symptoms are actually coming from the hip. And then in step 2, once we know we are actually dealing with the hip joint, we need basic imaging to decide which hip pathology might be causing the pain. And then when you get to step 3, which is to decide how you're going to treat this hip pathology, this is where advanced imaging and diagnostic injections can really help us. And in reality, the list of diagnoses in step 2 is probably much more extensive, as are the hip preservation treatment options. While diffuse arthritis is a contraindication to hip preservation, a focal, relatively small osteochondral defect can be treated with an open surgical hip dislocation and an Oates procedure. So this is a 30-year-old patient. He presented with hip pain. He had an osteochondral defect on imaging. And for him, we did a surgical hip dislocation and Oates to address that focal cartilage defect. So here you can see 1 year post-op resolution of the osteochondral defect after his Oates preservation. So in this instance, we thought, well, this really did the trick. We preserved his hip. But in the knee, we know a lot more about Oates. The survival rate in the knee has been shown to be up to 85% at 10 years, but we don't know how to translate this to the hip. Especially considering that in the knee, a lot of times these procedures are combined with an osteotomy, and we can't really do that with the hip. This one case series found that femoral head Oates had a survivorship of about 86% at 2 years, 67% at 9 years, but these reports are very limited, and the size of the graft that they used was less than 2 centimeters. And if I go back to that patient that I showed you earlier, this 30-year-old patient who had the Oates procedure, he did well initially. He came back 2 years later, though, had worsening hip pain. He had developed heterotopic ossification, and that was likely asymptomatic. But even though his hip looked great on imaging, really no evidence of that osteochondral defect anymore. He had pain that was not treated and ultimately went on to get a total hip replacement. Now, here's another diagnosis which we can potentially treat by hip preservation. That's coxa profunda, or an overcoverage of the hip socket. Now, the surgical hip dislocation was initially described as a standard treatment for femoral acetabular impingement, but now that our hip arthroscopy technology has advanced so much, we really don't do surgical hip dislocations nearly as often. But I would say coxa profunda is one of the diagnoses that we use a surgical hip dislocation for. Additionally, severe hip deformity, whether it's a significant version abnormality or a high riding trochanter, these are all indications for doing this much more morbid procedure. And then this allows you to see the femoral head and perform an Oates. So here's an example of a 30-year-old female roller derby athlete. She presented with right hip pain. She had coxa profunda on imaging, a diminished femoral head neck offset, and a labral tear. And so for her, we performed a surgical hip dislocation with, you can see we actually chiseled away the extra acetabular rim. And then we performed an open cam decompression as well as an open labral reconstruction with allograft. And post-operatively, this 30-year-old patient had a less constrained joint. She had improved hip function, range of motion, resolution of her pain, and she was able to get back to her roller derby. Now, another gray area of hip preservation is with SCFE and Perthes. So these are pediatric diagnoses that we know lead to hip arthritis. In SCFE, the femoral metaphysis translates anteriorly and externally rotates, while the femoral epiphysis actually stays in the acetabulum and falls posterior and inferior to the metaphysis. So this forms a cam-like lesion that's actually just the prominent femoral neck. And so in SCFE, this cam lesion can cause pretty significant impingement on the acetabulum and cause cartilage damage. And in some cases, we can preserve this hip with hip arthroscopy, but in some instances, we need to use a much more advanced open procedure. So this is a case of a 20-year-old female. She had a history of SCFE. It was pinned in situ. They removed the screw. And post-operatively, on the left, you can see that post-op this SCFE pinning, you can see she has this classic femoral neck deformity. So I did a hip arthroscopy on her, and you can see that it's not quite normal. You can still see a translation of the femoral head, but it looks much more normal, and we were able to avoid a much more invasive procedure for her. But here's another example of a SCFE hip. So this patient presented with an acute onset of hip pain at the age of 15. At that time, he underwent in situ pinning. And then over the years, he continued to have pain and the development of chondral wear in his hip. So another surgeon performed a surgical hip dislocation, open cam resection, wall recession, relative neck lengthening used an allograft in the wedge in the greater trochanter. So now at this point, this patient with a history of SCFE has now undergone an open surgical hip dislocation at the age of 17, and he already has the beginnings of significant arthritis in the hip. But despite this second intervention, his joint continued to deteriorate. So here you can see reactive osteophytes. He's got a recurrence of this cam-like lesion despite his open cam resection. And over the years, he has now ended up with this arthritic hip. And at the age of 25, this is probably best served with a hip replacement. Now, there are additional procedures that can be attempted for SCFE, such as the modified Dunn. And this is just one example of a much more intricate hip preservation option, but they're quite involved. And if things go wrong, you can see the outcomes such as avascular necrosis can occur, which is a terrible thing in a young adolescent patient. So multiple studies have shown that the longer the duration between SCFE pinning and hip arthroscopy, the worse the cartilage wear. So perhaps one solution that we could offer is to prophylactically perform hip arthroscopy after every single SCFE is pinned. And I'm not a pediatric orthopedic surgeon by training, but this is an interesting topic for discussion. Now, another challenging diagnosis, as I mentioned, was Perthes. So Perthes represents an idiopathic osteonecrosis or avascular necrosis of the femoral head epiphysis. And this is an example of a 30-year-old patient that came to clinic with many of the adult sequelae of undiagnosed Perthes. So he was 30 and presented for the first time ever in his life with hip pain. But he has, as you can see here, coxa magna, trochanteric overgrowth, coxa breva, and acetabular dysplasia, which are all common things in adult Perthes. So in this patient, given the fact that he had good articular cartilage, we performed a surgical hip dislocation, a relative femoral neck lengthening, and then a concomitant PAO. We also performed an open cam decompression at the same time. But here's another patient with perthes. So this is a 27-year-old female. And if you look closely at her femoral head, she has a large osteochondral defect. So the procedure I just described likely wouldn't offer her any improvement in symptoms, and it may make the most sense for her to go straight to a total hip replacement, even though she's only 25 years old. So even in the seemingly straightforward diagnoses, the limitations of hip preservation are very important to consider on a case-by-case basis. So this is a patient, if we look at her right hip, most surgeons would say she has a lot of hip dysplasia. She has too much joint space for a hip replacement. And so hip arthroscopy is not a great option because of the dysplasia. Cartilage looked reasonably good on MRI. She did have a small area of subchondral cystic change. So the answer should be a periacetabular osteotomy, right? And now with our post-free traction table, I can perform both hip arthroscopy and PAO in the same surgical setting. So you can do everything at once. And you can see this picture on the right shows you the 3 scope portals and the PAO incision and the 1 drape that we use for both of those. But now what if I tell you that that patient we were just talking about is 51 years old. She already had a left hip replacement because she was previously very dysplastic on that side and had early arthritis. So now that PAO is not such a straightforward answer anymore. And one of the common complications, as I mentioned earlier, in older patients is non-union, as you can see in this 42-year-old female. And usually this happens at the pubic cut. It can result in stress fractures in the inferior pubic ramus, as you can see with the yellow arrow. And if a non-union occurs, which is much more likely in patients over the age of 35, the subsequent treatment is bone grafting and plating of that non-union. And I'll tell you, in this patient, 42-year-old female, after she had this surgery, she was wishing she had just had a hip replacement the first go around. So back to our 51-year-old patient with right hip dysplasia. We talked about the PAO, the risk of non-union, the fact she already had a little bit of cartilage wear, and this patient opted for the right hip replacement as well. So perhaps a solution to avoid situations like this would be to start screening for adult hip dysplasia early in life, and once again, perform prophylactic PAO surgery, since we have good evidence that PAOs significantly decrease the risk of developing arthritis. But again, a topic for discussion because that's not current standard of care. So now that we've covered some of the technical details of the limitations of hip preservation, I'd really like to move on to the bigger picture limitations that we're facing. First, the losing battle against the hip replacement. So hip dysplasia is one of the leading precursors of osteoarthritis. It's been reported that up to 40% of all hips undergoing a hip replacement have underlying hip dysplasia. We also know that femoral acetabular impingement is one of the leading causes of hip arthritis. So if hip dysplasia and femoral acetabular impingement are the leading causes of hip arthritis, it goes without saying that some patients with hip dysplasia and with FAI are actually going to need a hip replacement instead of hip preservation surgery, especially if they're diagnosed too late in the process. So here's a reason why I find standing films very helpful in my practice. So this is a 50-year-old patient. She had good joint space on her supine AP pelvis x-ray on the left. She was referred to me for evaluation of hip preservation surgery. And we got a standing x-ray just 2 months after her supine x-ray, and suddenly you recognize she has 0 joint space. So really important, especially in arthritic patients. It's also important not to miss the occult arthritis, where an x-ray may appear normal with good joint space, but the patient actually has subchondral cystic changes that you might only be able to see on MRI. So these patients probably won't do well with hip preservation surgery either. Now, the hip replacement was coined the operation of the century in the Lancet in 2007. And certainly the benefits of the hip replacement include that it's a one and done surgery. The surgery itself is much faster than any of the hip preservation surgeries that we do. The hip replacement addresses all potential sources of pain, including the cartilage, the labrum, adhesions, loose bodies, dysplasia. And it has a similar, if not faster, recovery than hip arthroscopy or periacetabular osteotomy. So we've also seen a shift in younger patients getting hip replacements. We have the advantage of robotics and advances in implants and technology. So you might be asking yourself after this slide, why doesn't everybody just get a hip replacement? Well, as successful as the hip replacement is, there are a certain percentage of patients that continue to be dissatisfied and have persistent pain, components wear out over time, and revision hip replacements are not as straightforward as primary hip replacements. So the decision really should be made on a case-by-case basis as to whether the hip is best treated by something I coined, and I apologize to the arthroplasty surgeons out there, but should the patient have demolition, which is a total hip replacement, or should we do detailing, which is hip preservation? So case by case is really important. So the next big picture limitation in hip arthroscopy has to do with the learning curve of these procedures. So I looked at the learning curve of orthopedic surgeries on PubMed, and these are just a select few that came to the top of the list. So robotic hip replacement, the learning curve is about 14 to 35 cases to maximize efficiency. A total ankle arthroplasty through a transfibular approach, it's about 16 to 21 cases of a learning curve. A reverse total shoulder arthroplasty, it's about 40 cases. A direct anterior approach to the total hip, about 43 cases. This is typically considered a little bit more challenging than a posterior approach. Periacetabular osteotomy, it's about 20 to 50 cases for a learning curve. Although there's been literature showing that if you do that 1-year hip preservation fellowship, your results in complication rates are consistent with an experienced surgeon when you come out into practice. And then we get to hip arthroscopy. So this is universally thought of as a pretty technically demanding, steep learning curve. And the learning curve for hip arthroscopy is over 500 cases. And in one study, the authors found that the failure of less than 10% after hip arthroscopy only happened after a surgeon had performed over 388 cases. And those with career volumes over 519 cases had significantly lower failure rates. So with the learning curve this high, there's a significant bottleneck in learning and becoming adept at these procedures. And it's also a challenging procedure to teach for any of you that have been scrubbed into a hip scope. You can attest to that. Now, lower volume surgeons have been shown to have higher rates of revisions, major complications, longer operative times, and higher readmission rates. And what defines a low volume surgeon when it comes to hip arthroscopy? So some say it's those performing less than 30 hip arthroscopies per year. But there are other studies that saying a low volume hip arthroscopist is anybody performing less than 102 cases per year. Now, interestingly, it appears that a majority of surgeons in the United States are performing less than 30 hip arthroscopies per year if they are a self-proclaimed hip arthroscopist. So a majority of hip arthroscopies in this country are being performed by low volume surgeons. So this might beg the question, if a low volume surgeon sees a patient for hip arthroscopy, should he or she just refer to a high volume surgeon? Well, that probably isn't a solution because the high volume surgeons are maxed out and the number of hip arthroscopies per year continues to increase. So fortunately, on one of these studies, based on a New York database study, it seems that higher volume surgeons are performing these surgeries on younger patients, whereas low volume surgeons seem to have a higher age in their patients, which might correlate with patients who have some arthritis already, and the stakes are probably a little bit lower. But what are the solutions to the learning curve? Well, I believe a big part of the learning curve is actually just being able to identify the correct patient. And so understanding the nuances of who is dysplastic, who has acetabular retroversion or hypermobility is extremely important. And as Abby can attest, my clinic notes are crazy in depth. So this is my radiographic measurements that I got on every single new hip patient, and I transcribe these into the note. And there are numerous radiographic measurements that exist to help us diagnose hip pathology. But because there's no single gold standard, it really is important for us to pay attention to all of these. And this is my standard series of radiographs, a standing AP pelvis, a 45-degree done lateral, and a false profile. And again, another reason to get a standing AP pelvis over supine is because supine films can often mistakenly give you the impression of acetabular retroversion or pincer lesions, and they can also falsely elevate the lateral center edge angle of the hip. So standing will give you a more accurate representation of the functional position of the hip. So for measuring these, it's also important to be very accurate when measuring. And so the lateral center edge angle, I'm showing an example of the same X-ray where the lateral center edge angle is measured with almost a 9-degree difference. And it's important to understand where to draw your lines in order to get an accurate measurement. Now, spending time in clinic learning how to diagnose if it's actually the hip will really help with the learning curve as well. So the hip is probably the joint that has the broadest range of pain locations of any other joint in the body. And the patient's history is incredibly important. So it's not that infrequent that a patient comes to clinic and says, you know, they have hip pain, but they trace out the L4 or L5 dermatome as they say, this is where my hip pain is. So looking at, you know, the back and adjacent structures is extremely important. It's also important to know how high the rate of asymptomatic labral tears is. So in young adults, there's up to a 70% prevalence of an asymptomatic labral tear on MRI imaging. And in patients over age 50 with hip pain, about 93% will have labral pathology. This is in contrast to pediatric patients where there's a very low rate of asymptomatic labral pathology. There's also a relatively high incidence of asymptomatic radiographic femoral acetabular impingement. So about 40% of the population will have a cam deformity on X-ray with no hip pain. And when you look at the athletic population, it's about a 55% prevalence of asymptomatic cam lesions. And so here's where advanced imaging can come into play as well. We have a low-dose CT protocol that gives significant insight into what the diagnosis is. So here you can see a cam lesion on the CT image. This is a pincer lesion where there's excess acetabular rim. And here's an example of what a subspine lesion might look like. So advanced imaging can really help differentiate what the diagnosis might be. And sometimes you don't realize how undercovered a hip really is until you get that 3D imaging. Now, this low-dose radiation protocol is about a 90% reduction in the radiation exposure compared to a traditional CT. So I've been told it's about the same as 3 pelvis X-rays or hip X-rays. So worth the information in my mind. And this is actually about the same radiation that you get with one single cross-table lateral radiograph. So also understanding which radiographs to get and minimizing radiation exposure is important. We can also measure things like acetabular version, which is obtained on the axial cuts of the CT scan. And then femoral version, which we spoke a little bit about earlier, is a really important factor in how the hip functions. And this is measured off of the CT as well. I'm a big proponent of diagnostic injections, and this can significantly aid us in understanding the etiology of pain and can be really used at every step of the diagnosis process. And then other ways to overcome the learning curve is to keep learning. So courses, webinars, articles, lectures, and meetings. And I do think that as surgeons, we have figured out tips and tricks on how to make hip arthroscopy more reproducible. And we're able to teach those to our trainees. So I hope this ability will allow those coming up in hip arthroscopy to have a much lower learning curve. And I'd like to see that study repeated because I do think with skilled surgeons teaching the next generation of hip arthroscopists that the learning curve will be lower in the future. There's also interest in virtual reality learning to improve hip arthroscopy skills. And this recent publication, there's been recent publications supporting this as an effective adjunct to actual surgery. Another way to overcome the learning curve is to follow your patients closely. So learn from your mistakes. And this is where patient-reported outcome measures come in. So patient-reported outcomes are really necessary to understand how we're doing and whether patients are getting better. And I like this quote by Dr. Stedman, who said, if a patient does not think he or she has a great result, then he or she does not. And as we know, collecting patient-reported outcomes are a lot of work, but it gives us answers to our clinical questions, results in modifications of surgical techniques, and can really change our practice. So I began collecting patient-reported outcomes my very first day of clinic in practice. I printed out paper forms and handed them to my patients and then transcribed them into a database later. And we've since moved to electronic collecting mechanisms, third-party resources. So this has really streamlined the process, but it takes a lot of work and a lot of follow-up. But we can answer questions and controversies by looking at patient-reported outcomes. So I'm going to go through a few of the questions we've been able to answer in hip preservation. So initially with hip preservation, we used to debride the labrum. But then we looked at patient-reported outcomes. We saw that patients did better with labral repair, and that's now the standard of care. Then the question of labral repair versus reconstruction came about. And the authors of this publication found no difference in post-op patient-reported outcomes and no difference in the patients achieving clinically significant outcome. And that supports that we basically just need to do what we want to do on a case-by-case basis, whether that's a labral repair or a labral reconstruction. Now, iliopsoas release was a very common technique in early hip arthroscopy, but this recent multi-center study demonstrated that patients had much poorer patient-reported outcomes after iliopsoas release, and so they concluded that we should not release the psoas tendon. Another technique question was whether to perform chondroplasty versus microfracture for full-thickness cartilage defects, and this study found that actually patients have similar patient-reported outcomes, and so the conclusion I've drawn from this is that we should do the less invasive procedure, which is abrasion chondroplasty instead of microfracture. And multiple studies have looked at whether capsule closure affects outcomes compared to non-closure of the capsule. And while there have been a few studies that do not show a difference, a growing number of studies really emphasizes that we should, based on superior patient outcomes, close the capsule after hip arthroscopy. So I would say the final limitation in hip preservation surgery has to do with the topic of our talk this morning, diversity, equity, inclusion within the field of orthopedic surgery. As I mentioned previously, females are more likely than males to undergo hip arthroscopy. In one recent paper looking at across the United States, 70% of all hip arthroscopy patients in the US are female. They're almost twice as likely as males to have hip dysplasia and need a periacetabular osteotomy. So most hip preservation patients are females. But why is this discrepancy important? Well, because as we look in orthopedic surgery with very few female orthopedic surgeons, and then you look in hip preservation, and I'd say that's one of the even least represented, there are fewer female orthopedic surgeons in hip preservation. There have been a number of articles recently talking about this term called sex discordance. So this looks at negative patient outcomes, including complications and death, and they seem to be related to the gender of the patient compared to the gender of the surgeon. And obviously in orthopedic surgery, the most common sex discordance is a male surgeon and a female patient, especially in hip preservation. And those female patients have worse outcomes with a male surgeon. Interestingly, the same studies found that if you're female, if you're a male patient with a female surgeon, you don't have worse outcomes. So it seems to be a specific to male surgeon sex discordance issue. And I mentioned this earlier, but in hip preservation, it's even fewer females across the board. And so I'd say to all the trainees in the audience, if you're interested in hip preservation, it's a fantastic field. We're learning a lot, we're doing a lot. So I'd really encourage you to join me so that I don't have to be that single person presenting all the time. But I'm also going to bring back my disclosure slide. So there was a study looking at representation on journal editorial boards, and the authors found that women make up only 9% of orthopedic journal editorial boards compared to about 21% of women making up general surgery, and then 35% of women making up internal medicine journal editorial boards. And we know that much of medical research is based on male patients, and that's generalized to all adults. We know that studies that show clinical outcomes in women differing from those in men are often ignored and not published. And we also know that research conducted by female researchers is actually more likely to emphasize the differences in findings based by sex and gender. But because orthopedic surgery has the least amount of female physician representation, you can see how the discussion of female hip preservation patients likely doesn't get the airtime it needs. And so we really do have to start at the top when we want more literature and more information about females, both patients and surgeons in general. So one solution for this problem is that as a group of underrepresented orthopedic surgeons, women orthopedic surgeons need not only to write more papers, but we need to review more papers. And of course, for me, this happens after kids' bedtimes on the weekends. And as I mentioned earlier, so that really limits what you can do outside of these activities. Now, remember, having a role model of the same gender and ethnicity is a positive factor for more women than it is for men. And so mentorship, sponsorship, advocacy, which we spoke about this morning, is incredibly important, especially in our women orthopedic residents. So in summary, while hip arthroscopy can accomplish much, and arguably more and more is becoming possible in this field, appropriate indications are key because patients can still have continued or even worsened symptoms from poorly indicated or poorly executed hip preservation surgery. And when thinking about open hip preservation alternatives to hip arthroscopy, keep in mind that these are large surgeries. They're often more difficult procedures to recover from. Patients can have continued pain, a protracted recovery, and complications such as non-union. So many of these cases, even though we might think we could try to preserve the hip, it's a very challenging decision as to whether we should try or whether this patient would be better served with a hip replacement surgery. And as far as the big picture limitations, there's no doubt that the hip replacement is a great option. And in some patients, as I mentioned, it might actually be the better option than hip preservation. The learning curve is incredibly steep for hip preservation, though dedicated hip preservation fellowships can help. And as I mentioned, we now have a deeper well of knowledge that will hopefully make that learning curve easier and less daunting for the trainees currently. Patient-reported outcomes require hard work to collect, but they're necessary for our improvement. And I think we need to all continue to increase the diversity in orthopedics and especially in hip preservation surgery. All right, so once again, thank you so much. It's been an honor to be here. Look forward to any questions.
One patient population that I still struggle with are so-called minds. Don't have over and I think the research would suggest that they may have for they're specific or radiographic parameters that skew.
Yeah, I agree. The borderline classification is incredibly challenging, and we actually hold a hip preservation conference at University of Wisconsin where a number of surgeons and radiologists come in and we present cases and we debate. And there's a lot of disagreement sometimes on how best to treat the borderline dyslexia patient. I would say as I've gotten further in my career, I am indicating more for a periodic osteotomy. I think the PAO has become such a streamlined procedure. Patients go home post up day one. It just fixes all the issues and leaves no questions remaining. Like you can fix the osteotomy coverage. But there certainly are patients, if they're less hypermobile, the honest angle, so that the trajectory of the hip socket, if it's more flat, then you might be more willing to scope the hip, or if there's low hanging fruit, a huge cannulation, or a loose body, or a big flat with cartilage, then maybe you're more likely to scope those patients. But it continues to be a challenge. But like I said, I think I'm turning more to the PAO is worth it. It's not that much bigger of a recovery than it is. So.
Trey, don't leave. I got this question pertains to you. So what to do with the tweener? It's a 50-year-old woman with a labral tear, like little bit of stuff you could probably scope, but enough arthritis to think that she might fail. Like that's the hardest patient for us because where do they go? I mean, there's a whole, I'd say a whole segment of our patient populations between me and Trey and Tracy and the other hip replacement. I mean, you sent JB off. He was so scared of the hip preservation stuff. But like, how do we treat that patient? Like, what's the right answer for them?
So, yeah, I've learned actually with my arthroplasty partners, we've made some mistakes on both ends. So I think femoral head cartilage wear is the kiss of death. So if a patient has a flap of cartilage on the femoral head and the weight-bearing surface of the femoral head, if they have subchondral edema or subchondral cystic changes on the femur, then I am much less likely to indicate them for hip preservation. And I've learned because I've tried in those patients and they have failed and ended up with a hip replacement. I think we can be a little bit more forgiving on the acetabular side, on the acetabular cartilage if they have subchondral cystic changes, especially that impingement zone, a little bit lateral out to the edge of the hip socket. I think it's worth trying. And I think getting that MRI is incredibly important for that occult dysplasia. So you can get x-rays and it looks like they have perfect joint space and then you realize there's a big pothole missing cartilage and that's what's causing their pain. But I've learned over the years, and one interesting thought, this is something I didn't know about, but learned from my arthroplasty partner, is that when he sometimes goes in and does a hip replacement on those patients that have pretty good looking x-rays, so good joint space superiorly, they actually have pretty significant cartilage wear inferior medially. And so when you do a standing x-ray, their head actually kind of sinks into that arthritic area, kind of nuzzles into that dehibernated area. And so that's causing all their pain, but their x-rays look really good. So I look for that as well when I'm evaluating x-rays, but I'd love to hear your thoughts too on that.
That was my question. If I got a time, I will ask the same question. The gray area, this is the patient we have to deal with every day at the clinic. So sports guy can do it or guy can do it. I appreciate you doing PAO. PAO is a good operation. And also thank you for recognizing total hip is, the surgery of the century. So last few years, like my practice, those people in the gray area, I will do more, some study and look at MRI with brain X-rays, identify if they truly have some hip pathology. If those factors there justify for a total hip replacement because the material is better, technology is better. Patient recovery is much better. So, from quality of life improvement point of view, we will losing the indicators for total hip replacement. On that part, like patient actually looks great, but I'm actually a focal, like a bone cyst on the femoral head. This is going to get worse with time. Any injections or physical therapy that are not going to help them. And the total hip actually works great. Their job, their quality of life, their family is a great operation for total hip replacement. Thank you very much. It's great talk.
You guys heard him. Yeah, all right. You heard him at some of my clinic.
Yeah, diagnostic injections, are you doing them personally or do you have a PA that does them?
So we currently send them to our MSK radiology departments. And none of us are doing them in clinic, but since you've left, we're having conversations because the backlog is pretty horrendous. So patients are having to wait 4 months for an injection. And so we're thinking of changing that in our clinic.
So you talked very briefly about prophylactic possible either hip scopes or PAOs maybe, but the PED world we sort of, like we'll fuse someone's spine from T4 to L2 sort of prophylactically based off data that says that if they have scoliosis, it'll get worse. Where kind of is the, mood in the hip world as far as I guess how close are we to that? Where people are getting screened and prophylactically getting a hip scope or something?
Yeah, I think we're very far away. And I base it actually on insurance denials. So, I do research to these scopes, and this is actually an interesting topic with arthroplasty because we scope a lot of arthritic knees. We'll scope it 3-4 times before they get a knee replacement. And that is not happening in hip, right? It is either you get a hip scope or you get a hip replacement. We're not scoping first in preparation for a hip replacement. So that's kind of an interesting dichotomy. But similarly, when I try to get hip arthroscopy approved, it is a gauntlet. I have to show they've done 6 weeks of PT in the current calendar year. Many insurance companies require a diagnostic corticosteroid injection. They have to have MRI evidence within the past year of labral tear. They can't have any evidence of arthritis. I mean, it goes on and on and on. So I can't imagine the day I call an insurance company and I'm like, this patient has no pain, there's nothing going on, but I'm gonna scope their hip. I just think, you know, we're so far away from that. And just having that data only published this past year has been, you know, I think this is the beginning of potentially, you know, screening, preventing arthritis, but I just think we're a ways away.
The spine surgery here seems like spine surgery in orthopedics is similar to the hip preservation in the sports medicine. A lot of the applicants are the male, like we, you know, the 32 applicants for the spine fellowship, only one female applied. So, how many your trainees in the sports fellowship or in the training of orthopedics doctor resident doing the hip preservation surgery?
So it's increased over the years, but you know, we don't have a lot of our residents going into hip preservation, even though we have a number of female residents in our program. I don't think, you know, we've had anybody in recent years go into hip preservation. But interestingly, we have had spine fellows at our institution, and we have one female spine faculty. So 25% of our spine surgeons are female, one out of 4. So, you know, I think we do attract the female spine fellows in that instance. We have a fellow coming in next year who is specifically interested in hip preservation, and you know, specifically said, I want to come to Wisconsin because, you know, of Hugh and Dr. Sharpella, and we have 4 female sports surgeons out of our group of 7. So I think, you know, I think it's attracting people in the right way, but it's taking time, and especially with the match process, you know, we're looking 1-2 years out, and if those residents are coming from programs where they don't have female spine attendings, they're not getting exposed to that, and I think you're seeing the trickle down as your applicants are.
That's good. Do you think it's time for like a new division, like hip preservation? Like you just go there, learn PAOs and scope, just like shoulder and elbow separate themselves. There's a lot going on in here to just put it under an umbrella of sports, maybe Pete's. Like I think it needs its own home. So Richard, think about it. Thank you.
That question.
There's a question.
Again, thank you for coming.
All right, thank you all.
Thoughts and